And finally, just to mention headache. This is something that I must confess we don't ask often enough. But if you do go and ask people quite often in the acute phase that they're sitting there with quite a bad headache. And part of the management, I think, is reassurance. People are often associate headache with something bad happening. You know, I'm going to have another stroke, I've got a brain tumour, and just reassuring that it's part of the natural history. They usually respond fairly well to standard analgesic treatments, and specialist referral isn't needed. But again, it's this association with other problems, you know, depression and anxiety, and making sure that we treat the whole patient. So that was my rather long list of complications. I've covered most of the ones, the commoner ones. But what I wanted to do was hopefully preaching to the converted, just to emphasize the importance of good multidisciplinary or interdisciplinary team care in managing complications. And 3 or 4 years ago, we had a PhD student working with us who updated the stroke unit review. And one of the things she did was she dug out a whole load of data on complications in patients who were managed in a stroke unit or a general ward setting. And these are all in clinical trials, so they were all matched groups. And what they found was that the frequency of several complications were significantly less common in the stroke unit group. To the left of this dotted line means less common in the stroke unit group. And where they stand completely clear, it was a significant result. And so we had chest infection, falls, other infections, that was mainly UTI, pressure sores, and stroke progression or early recurrence. These were all less common in the stroke unit group. And when we looked at the certified cause of death, so among the people who died, in the general ward group, there were about 5% died of cardiovascular problems, 7% of immobility, 8% of neurological. And in the stroke unit group, there were the particular area where causes of death were reduced was in those attributed to infections and DVT and complications of pressure sores. So again, it just reinforced the same message of the importance of multidisciplinary care. And I think it's interesting to speculate, you know, why would something so touchy-feely like interdisciplinary working have an impact on something so hard an outcome as dying from a chest infection? And I think there's a number of things, you know, the patient group are uniquely disadvantaged when it comes to complaining what's wrong with them. They often can't communicate. They're often got reduced awareness of one side of the body, so they're often not well placed to actually tell you what the problem is. And so you need staff who are aware of the possibility of the complication, are looking for it, and also are, you know, if pyrexia develops, are aware that this is a significant observation. And also to be aware that complications can present in very vague ways. I'm always delighted when a multidisciplinary meeting, you know, somebody says, you know, it's Mrs. So-and-so is just not right today, you know, have you thought of a urinary tract infection? Or this gentleman's walking's just not right, are you sure they've not got pre-existing Parkinson's? And I've several times we've diagnosed Parkinson's because the physios told me that's what they've got. And you know, I think you need to be alert to all these rather vague presentations. And of course, we were talking before this presentation on what marks out what a stroke unit is, and several of the things that stroke units tend to do, I think are all good news. You know, having a protocol for how you're going to manage people to prevent infections, for instance, having a policy of mobilising early, having staff trained to know about infections, and having, you know, the medical staff ready, prepared to go in with the appropriate treatment of aspiration pneumonia, for instance. It's a whole team approach. And many of the things that go on in a typical stroke unit should be identifying and preventing and picking up early common complications. So swallow assessments, good management of food and fluids, you know, ready use of antibiotics, awareness that hypoxia might mean chest infection or pulmonary embolism, you know, good positioning and handling, early mobilizing. It's the same story that comes through again. And also the training of the staff. I think one of the key characteristics of stroke units is staff being trained and interested in managing stroke. And I think training and increased team awareness and good interdisciplinary communication mean that these things are picked up early and are treated early. And I think there's lots of good rationales how this might work. So just to summarize, I hope I've convinced you that strokes are a major factor in recovery. Complications are a major factor in recovery after stroke. Particularly if there's one group you want to worry about, it's the frail elderly with a more severe stroke. They're at very, very high risk. And I think the clinicians need to be aware of these risks. I think stroke units definitely work partly through reducing the impact of complications, but the evidence base for specific treatments is often limited. And I think future considerations, there's certainly, we need to better understand the basic principles of some of these complications. I mentioned fatigue, pain. We need to better identify people who are at risk. We need better evidence for strategies for picking up complications, and we need better evidence for specific treatments. So basically we need to do everything a bit better. So with that challenge, I'll say I expected times like these, but I didn't think they'd be so bad, so long and so frequent. So with these challenges, I'll say thank you for your attention.
Thank you, Peter. Just to be able to link in with all our colleagues at the state, I'll just work a little bit with technology here and try and bring it back so we can see all our other staff around the state. Now we can spot some people up in the different corners there, and we actually have 7 sites linked up with today's presentation. So thank you very much, Peter, for being able to be able to link us all in to your knowledge and thoughts. What I'd like to do is to especially link in questions from around the state now. So if people, we'll see how we go to start off with. We can go site by site if need be, but actually we might try that just to see how we go. Is there, just from Bernie, please, are there any questions from there? Just giving a few seconds to be able to unmic if need be. Okay, just going on to Devonport.
Yes, there is a question. It's Trudy. I have a gentleman in his mid-70s who has had a right CVA about 2 years ago. He still has very high emotionalism. He does suffer with agoraphobia. I did a geriatric depression scale which showed some mild depression, although I suspect that depression's a little bit more than mild. Mainly because he likes to stay. He likes to stay in bed of a morning. He doesn't like getting out of bed, and he has quite low motivation, although he really wants to get back to independence. And the agoraphobia, from the discussion I had with that, was really his fear of going outside and falling again. He has had a couple of falls. So I guess there's two questions there, Professor, and that one is, can you tell me a little bit more about the agoraphobia? And two, does this patient have a sense that maybe some antidepressant medication may be useful for him? What are your thoughts there?
Yes, thank you. That sounds particularly complicated because there's potentially a combination of agoraphobia and fear of falling, as you're describing. The agoraphobia, as far as I'm aware, is in stroke survivors is essentially not that different from agoraphobia generally, and I think the management is similar also. And what we would do, if it's really problematic, you may well want to involve a psychiatrist. Clinical psychology input, if you have access to that, can certainly be helpful. But some of the SSRI antidepressants are particularly good for agoraphobia, and you may want to get some psychiatric input to look at that. But I suspect you're talking about a combination of approaches for this gentleman. But as you say, I think I would have a very low threshold for thinking of depression here, and particularly if he, in quotes, lacks motivation. That's so commonly a feature of depression. And it sounds like you've sort of all the right alarm bells ringing. And I think the important thing is to be making sure that he's got the appropriate medication if that's going to be needed.
Okay, thank you. Just with the problem with the agoraphobia / fear of falling is, whilst he's doing home exercises, working on his strength and balance, we're having there's lots of barriers for getting him out doing walking. So that's where I thought if we can address these issues, hopefully we can then progress him with his mobility.
Yes, absolutely. And I think you mentioned, I think you said he had emotionalism as well.
Very high, yes.
Right, okay. Because again, that often responds very well to even low doses of antidepressants, and you may well find that actually treats a number of the problems that you're facing.
Thank you very much.
Often people, I think, are a bit resistant to starting antidepressants, but I think if you explain that, it's not that they're going mad, that these are common consequences of stroke, and it's to help them feel better. That, I think, often persuades people they should give it a try.
Yeah. Okay. Thank you very much.
Thank you.
Just going on to our next site. Are there any questions from Ulverston?
No questions.
Thank you. Latrobe.
No, none from us either, thanks.
Okay. On to Hobart, to the DPM venue.
No questions.
Okay. Repat in Hobart.
No questions, but thank you very much, Professor.